Hi, everyone. Welcome to our Thursday webinar series. My name is Lourdes, and I am the Director of Patient Services with the Cholangiocarcinoma Foundation. I am glad to introduce our speaker for today, but before I do that, I have to remember to remind you to please put any questions you might have for today's webinar into the chat or Q&A, and please make sure that your questions are general in nature. Dr. Haley Ellis is a medical oncologist and clinician-scientist at Massachusetts General Hospital, Harvard Medical School, where she specializes in biliary cancers and leads clinical trials. Her translational research focuses on cholangiocarcinoma tumor biology and therapeutic resistance mechanisms. She trained at Dana-Farber Cancer Institute, Memorial Sloan Kettering Cancer Center, Washington University, and the University College Dublin. In addition to her clinical and research work, she is a member of the New England Care Team. Thank you for being here, Haley.
Thank you so much, Lourdes, and to the Cholangiocarcinoma Foundation and to Jazz Pharmaceuticals for putting together this really exciting and educational webinar on the treatment of HER2-positive advanced biliary tract cancers, which is a very rapidly evolving space. So I'm excited to share some of those updates with all of you today. This is me. And here are my disclosures. And so the objective of today's webinar is we'll provide sort of a very brief overview of biliary tract cancers, which many of you are already very familiar with. And then really the focus of today is going to be on the role of the HER2 biomarker in biliary tract cancer specifically, why testing is so important. And then again, we're going to discuss all of the exciting advances that have been happening in the treatment landscape in these HER2 positive cancers. So briefly starting with an overview, this is not new information to anyone in this group, but here is the biliary tree. We classify biliary tract cancers based on where in the biliary tract tree they originate. So we have gallbladder cancer as well as cholangiocarcinoma, which is further subdivided into intra and extrahepatic cholangiocarcinoma. These are rare cancers. We see about 13,000 cases per year in the US between gallbladder cancer and cholangiocarcinoma. While these are rare cancers in the US, they're much more common in other parts of the world. Gallbladder cancers, particularly we see high rates in places like South America and Northern India. And cholangiocarcinoma, we see a little bit more here in the US, and the incidence of intrahepatic cholangiocarcinoma in particular has been on the rise in the US for decades. And by 2040, intrahepatic cholangiocarcinoma, in addition to other liver cancers, are predicted to be the third leading cause of cancer-related deaths. So this really highlights the important work that we're all doing to try and make positive advances for these cancers. One of the challenges with biliary tract cancers in treating them is that most of these cancers present at an advanced stage. There's usually very little symptoms in the early stages of biliary tract cancers. Sometimes with extrahepatic cholangiocarcinoma and gallbladder cancer, people may present with obstructions of the bile ducts where we see things like jaundice, pain, fevers, bowel changes, urine changes. But unfortunately, most people present with unresectable, locally advanced, where these tumors are involving important drainage and blood vessel supplies of the liver, or metastatic disease where the cancer is spread outside the bile ducts in the liver. And that's where a lot of the treatment has been focused on how do we move the needle forward in a positive way. Luckily, over the past 5 years, there's really been an explosion of treatments in both the first line setting and the second line setting. As many of you know, our new standard of care for first line treatment for advanced or metastatic biliary cancer is a combination of chemotherapy and immunotherapy. We've now had 2 large phase 3 trials around the world that have shown that adding immunotherapy to chemotherapy helps people do better. And then in the second line setting, and this is where the biomarker testing is so important, we have a growing list of treatments available that are targeting some of these specific biomarkers. And so here's a list of just some of the treatments we have available now to help treat biliary tract cancer. You can see here the targeted therapy list on the right continues to evolve what it feels like by the month. And one of them I just wanted to highlight, for example, though it won't be the focus of today, is KRAS. So KRAS is a biomarker that we see very commonly in many cancers. It's the second most common change across all cancers, including tumors like lung cancer, colorectal cancer, pancreas cancer. And for years, this was felt to be an undruggable target. So we had all these patients with these tumors having a KRAS mutation that we didn't have any good treatments for. And that has changed in recent years, where now we have approved drugs for some of these select KRAS mutations, and there's a number of really promising trials as well. So all of that to say, just because there are biomarkers that we may not have targeted therapies for today, things can change very rapidly in the future, which is very exciting. So the bulk of today will be focused on the HER2 biomarker specifically. So HER2 plays a really important role in regulating how cells grow and develop. And some cancers, including biliary cancers, can have too much HER2, which allows cells to grow faster and drive cancer growth. We classify this having too much of HER2 in two ways: amplification and overexpression. And this is a really subtle distinction, but it's really important to understand the distinction between this. So amplification reflects having extra copies of the HER2 gene itself. And you might also see HER2 called as ERB2 on any biomarker testing reports. Those are the same name. And genes are these tiny blueprints. They're changes in the DNA that tell tumor cells to make proteins. So amplification, again, reflects that there's too much of the gene itself, whereas overexpression reflects having too much HER2 protein. And so again, in either one of these scenarios, when we have too much of the HER2, either on the gene level or the protein level, that can make the cells grow faster, and these are often more aggressive cancers that have tougher outcomes. So HER2 is found actually across all subtypes of biliary tract cancers. Most commonly in gallbladder cancer, we see HER2-positive biomarker in up to 30% of gallbladder cancer. A little bit less commonly in extrahepatic cholangiocarcinoma and intrahepatic cholangiocarcinoma, but we still see it in a sizable percentage. So highlighting the importance of testing across all biliary tract cancer subtypes. This is where I think the most important point of this discussion today comes into, is the testing. So the Cholangiocarcinoma Foundation has done a fantastic job at raising awareness for the importance of biomarkers and testing for them. And increasingly, many patients are having next generation sequencing done of their tumor to look for many of these biomarkers. And that has been exciting to see these numbers go up over time. What next generation sequencing is looking at, particularly in the case of HER2, are changes at the DNA level. So these are gene changes. And this can be done either in the tissue and or in the blood. And we're looking to see, again, that amplification change. Are there too many copies of the HER2 gene? That is sort of one aspect of how we can look for HER2. On the other hand, we have another set of tests that are tissue-based tests. One of them is called immunohistochemistry or IHC testing. Going back to that first slide, this is looking at the overexpression or the increase in the protein on the cell surface. And in situ hybridization or IST testing is often a reflex test that's done in conjunction with immunohistochemistry, and that's looking at the DNA changes. So the two types of testing on the right are looking at the DNA. The one on the left is looking at the protein. It's important to look at all of these across the board. The advantage of the tissue-based tests like immunohistochemistry and ISH testing are that they are fast, they are cheap, and they are widely accessible. Next generation sequencing, again, is being increasingly used, but doesn't sort of capture the full breadth of looking at HER2. So we're going to talk about why it's so important to do all of this testing. So our current gold standard that's recommended by our guidelines to look for HER2 is the immunohistochemistry testing. So the way that we look for immunohistochemistry in biliary tract cancers is actually by using the stomach cancer guidelines. You may have heard that HER2 is a biomarker we see more commonly in tumors like stomach cancer and breast cancer. Stomach cancer is different from breast cancer in that it's much more heterogeneous, meaning that the HER2 levels within different tumors in the same person can have different levels of HER2, and even different spots within the same tumor can have different levels of HER2. So the way that we score and look at HER2 is different across different tumors. But in biliary cancer, we follow the stomach cancer guideline model. And again, that's based on looking at the percentage of cells and the strength of the staining that we see for HER2. And we have sort of 3 different buckets that we categorize them into. When we see a score of 3+, that is HER2 positive, and that is sufficient testing. On the opposite end, if you have a score of 0 or 1+, that would be HER2 negative. And many tumors can find themselves in sort of this middle ground where they have 2+, where we recommend further testing using another one of those tissue-based tests called ISH, or in situ hybridization. And in this case, we're not looking at the protein level, but at the gene level. And so if we see that the gene is amplified or that there's too many copies of the HER2 gene, that is called HER2 positive, whereas if it's not amplified, that's HER2 negative. And so finding these HER2 positive cases is so important to open the door to other treatment options. This to me is the most important slide of this talk, and this was actually a poster that was just presented at one of our national conferences in January. And this was a study that was looking at people that had stage 4 biliary cancers. There was about 300 patients, and they were looking at different ways of testing for HER2 by sort of this next generation sequencing NGS testing, which is what many people think of when they think of biomarker testing when we're looking for multiple different biomarkers, as well as IHC testing, which is specific to the HER2 biomarker itself. And they found in this cohort that there was about 25% of patients across biliary tract cancer subtypes that were HER2 positive, that most of these patients were identified using this IHC classification system. But here on the right, I think, is the really important message to highlight why it's so important to do both NGS and IHC testing. So you can see here in this graph that for tumors that were not HER2 amplified by next generation sequencing testing, and again, this is the testing that most people are having done, there are 15% of patients who have HER2 positive tumors that are being missed. And this is really critical because, as we're going to talk about, there are a number of both approved and guideline recommended therapies for people that have HER2 positive tumors. So, the NGS is looking for amplification and the IHC is looking for overexpression. This is not a one-to-one correlation, so it's really, really important to test for both. And the great thing about IHC, to sort of add on to NGS testing, which most people are having, is again, it's cheap, it's fast, and it doesn't require a lot of tissue, which can be a big issue, particularly for tumors like extrahepatic cholangiocarcinoma and gallbladder cancer, where actually accessing enough tumor can be a big challenge. So now we're going to move on to talking about some of the exciting treatment in HER2 positive biliary cancer. So this is sort of giving you a breadth of the change that we've seen only in the past, several years for HER2 targeted therapies. And we'll briefly go through some of these different trials. So this is the My Pathway phase 2 trial. All of these trials were looking at patients that have HER2 positive biliary cancer. And the way in which they classify that is slightly different amongst all these trials. But this was looking at a combination of HER2 targeted antibodies called trastuzumab or Herceptin plus pertuzumab and Perjeta. And again, this is a lot of data on these slides, but I just want you to get a sense of some of the numbers here as sort of a comparison, though it's not exactly a one-to-one comparison when we're looking at some of these trials. So the overall response rate, what that reflects is the chance of having meaningful tumor shrinkage. And that was 23% with this combination. We saw median progression-free survival, meaning the time from starting a treatment to the tumor growing, of about 4 months. And then here on the right, you can see some of the risk of side effects. So about 60% of patients did have side effects on these treatments. Most of them were pretty mild and low grade, but things like diarrhea, changes in liver numbers, and infusion reactions were seen. And so this was one of the earlier trials that was looking at HER2 combinations. And this is not FDA approved, though this is a guideline recommended option for patients that have HER2-positive biliary cancer. A different combination of drugs, again, one of the same antibodies from the prior trial called trastuzumab in combination with a drug called tucatinib. And tucatinib is actually not an antibody, but is a small molecule blocker that goes after the HER2 activity hub or the kinase domain. And this we saw, slightly higher response rates, about 47%, progression-free survival about 5.5 months. And you can see some of the safety data here on the right. Again, probably some higher rates of treatment-related side effects. Tucatinib tends to have a lot of diarrhea side effects that can be a little bit challenging to manage. But this was another sort of option for patients that was extrapolated from colorectal cancer. This Destiny Pan-Tumor02 trial is looking at a type of drug called an antibody-drug conjugate, an ADC, called Enhertu, or trastuzumab deruxtecan, which is the long name there at the top, or TDXD. An antibody-drug conjugate is an antibody, sort of like a heat-seeking missile. So the antibody is able to bind to tumors that have HER2 on it, and it's attached to essentially a little chemo bomb. So the drug is able to bind to the tumor cell and deliver the chemo directly into the cells. And this is a drug that's now actually has approval for all patients with tumors that have a HER2 biomarker, including biliary tract cancers. And this is data specifically that was seen in BTC. And you can see, there's sort of two groups oftentimes that we look at in these trials, sort of the all-comers, where we're looking at different levels of HER2 expression, but really it's the IHC3+, which is that highest level of HER2 biomarker, where we see the best response rates of more than 55%, which is very exciting. We always like seeing these numbers with targeted therapies. And again, on the right, you can see that some of these survival outcomes are improved, sort of the higher levels of IHC that we see. In terms of safety with these ADC drugs like trastuzumab deruxtecan, because it's an antibody that's linked to a chemo, many of the side effects we see are chemo-like side effects. So you can see that about 40% of patients had pretty significant treatment-related side effects. That would be things like nausea, low blood counts, hair loss, fatigue, all very chemo-like side effects. But it's great to have this now as an option for patients who have been previously treated with chemotherapy. And this trial actually even looked at patients who had had prior HER2 targeted treatments as well, and still saw some of these good responses. But now we'll move on to sort of the latest approval in this space, which is called zanidatamab. So zanidatamab has a novel mechanism. So this is what we call a bispecific antibody. And how this works is that it's actually binding to two different parts of the HER2 protein. And that mechanism allows it to work in a unique way compared to some of these other drugs that we had previously spoken about. So again, the HER2 sits on the surface of the tumor cells, and when there's too much of that HER2, that's what's telling the tumor cell to grow. Zanidatamab can bind to the tumor cell and sort of attach onto the HER2. And when that happens, we get these clusters of the drug with the HER2. And that allows your immune system to detect and recognize this cluster of the drug and the HER2. And so your immune system can attack and kill the tumor cells. And there's a number of sort of specific ways in which your immune system can recognize and kill these tumor cells. But this is a really unique mechanism of action that this drug has. So zanidatamab was studied over a few different phases of drug development in these different trials. The first phase was looking at zanidatamab by itself and showed that it was safe and had sort of really promising tumor efficacy, which is when we moved on to the phase 2 study, which was looking at patients that had HER2-positive biliary cancer. And that's what I'll share with you, some of the data from that now. So the Horizon BTC-01 study was a global study that was looking at 80 patients that had HER2-positive biliary cancer. There were initially sort of two cohorts that they looked at here on the left. One was the HER2-positive, which had 80 patients. All of these patients had HER2 amplified tumors, meaning that there were too many copies of the gene, but they broke it down into what the protein expression was. And when they looked at this study, they found that people that had 0 or 1+ tumors did not show responses, which is consistent with data that we see in other HER2 treatments. So most of the effort was focused on this HER2-positive group. Zanidatamab is an IV drug that's given every 2 weeks. People were scanned about every 2 months, just like we would do on standard of care. And one of the side effects that we'll talk about is infusion-related reactions, which can happen with some of these antibodies, but with pre-medication, it tends to be very manageable. So this, again, because HER2 is seen across all different types of biliary tract cancers, all BTC subtypes were included. Again, the majority were gallbladder cancer, about 50%, followed by intrahepatic and extrahepatic cholangiocarcinoma. Most people had stage 4 tumors, meaning the cancer is spread outside of the bile ducts and liver. And here at the bottom, you'll see that only about 25% had prior PD-1 or PD-L1 inhibitors. That's immunotherapy. When this trial started, which was back in September 2020, that was prior to the approval of drugs like durvalumab or Imfinzi or pembrolizumab and Keytruda. And again, this is a global study where there are some countries that don't have access to immunotherapy. So this is the efficacy data that we're seeing with zanidatamab. So you can see that in the HER2-positive group, which includes both IHC 2+ and 3+ tumors, that the response rate was 41%. Then when we look specifically at the highest level of HER2, that the response rate is 52%, which is very exciting. Median progression-free survival of over 7 months. And for people that respond, their responses last a really long time, over 1 year at 15 months. And we even see, a small selection of patients that had a complete response, meaning that their tumors that we're tracking over time actually completely disappear. This is always what we love to see in oncology is overall survival data. So knowing that these treatments help people live longer, again, recognizing that this is a single arm study, this isn't being compared to other treatment, but seeing that in the IHC 3+ group, and median overall survival of 18 months. And again, this is in people that have been previously treated, oftentimes with chemotherapy before, and for people to do so well on the second treatment is very promising. Though again, we always want to keep pushing the needle forward even more. The safety profile of zanidatamab is actually quite manageable. There sometimes is apprehension when we hear about mechanisms of drugs like bispecific antibodies that people will have sort of significant immune-related reactions, but that's not the case here. Mostly it's low-grade diarrhea and infusion-related reactions, which are often quite manageable. Decreased ejection fraction has to do with the squeeze function of the heart. And this is essentially a class effect of all drugs that hit HER2 is having some chance of heart toxicity, but this is usually reversible. And so excitingly, based on all of this data showing that, zanidatamab is, really showing a significant improvement in some of these outcomes, it was approved back in November 2024 for people that have advanced biliary tract cancer that is HER2 positive, and this is IHC 3+. The Horizon BTC 302 is now the confirmatory phase 3 study where we're looking at adding zanidatamab to the standard of care first-line therapy, which again is chemotherapy plus or minus immunotherapy. This is going to be a study that's run around the globe, but here are some of the sites that will be available here in the US. And this is really, really exciting, and I think could potentially be practice changing because right now all of our targeted therapies are available for patients in the second-line setting, meaning after things like chemotherapy and immunotherapy has stopped working. So I think it will be really exciting to see when we bring targeted therapy to the frontline setting, because I do think that when you have biomarkers like HER2, which are so important for tumor growth, I think it's a really good strategy to try and bring that kind of treatment up earlier. So questions that would be important to talk to your team about would be, has HER2 testing been done by NGS and or IHC? Again, I would argue that IHC testing is becoming increasingly important. Drugs like zanidatamab and trastuzumab deruxtecan have approvals based on IHC 3+ tumors. Again, NGS testing is not going to capture all tumors that might be eligible for these kind of treatments. So given that IHC is very accessible, not a lot of tissue is needed, I think it's really important to test for both NGS and IHC for HER2 specifically. And then if your tumor is one of the tumors that has this HER2 biomarker, what targeted therapies are you eligible for? Now we have 2 approved HER2 targeted treatments. We have a number of guideline recommended available options. The sequencing of these treatments is where there remains some work to be done, but I think, having that discussion with your team about, based on your prior treatments, side effects, what's the best strategy for you to really personalize it as much as possible. So in summary, HER2 is a really important and actionable biomarker that we see across all biliary tract cancers. Early biomarker testing is really important. Ideally, doing this at the time of diagnosis. And again, it can potentially even make you eligible for first-line trials, but certainly opens the door to second-line and later treatments. When possible, if there is tissue available, both next-generation sequencing and IHC biomarker testing should be done for HER2. And as you can see, just seeing the growth of all of these treatments in the HER2 space, there's really meaningful activity that's happening, and the safety profile is very manageable in many cases as well. So I will pause there, and I'm happy to take any questions.
Thank you so much. If anyone has any questions, please put them into the Q&A or the chat. How does PD-1 have something to do with HER2?
Great question. So in biliary tract cancer specifically, we haven't found that PD-1 or PD-L1 testing has proven to be a really informative biomarker. In stomach cancer, for example, that's an important test that's done to determine if someone will be a better responder to things like immunotherapy. But certainly there's not a real role for in biliary tract cancers yet. So I would say there's no direct correlation between them, and testing for HER2 would be important regardless of if you had PD-1 or not.
Okay. Does the NGS and IHC dual testing recommendation carry over for other mutations other than HER2?
Good question. So there's not IHC or immunohistochemistry testing for all biomarkers. For example, biomarkers like FGFR2, which is one of the common biomarkers we see in cholangiocarcinoma, where we commonly see changes like fusions or less commonly mutations. These would be changes that would be seen on NGS alone. When we look at overexpression levels of biomarkers like FGFR2, again, that hasn't proven to be a really informative biomarker in BTC specifically. So IHC testing is specific to HER2, and that would be really important to test for. Another important IHC marker that should be tested in all biliary tract cancers is something called mismatch repair. And that can be, something that's checked on NGS as well, but there is an IHC test available that looks at mismatch repair. And when we see people that are deficient in some of these proteins, that makes them very likely to respond to treatments like immunotherapy. So that would be another important immunohistochemistry test to test for, would be HER2 and mismatch repair.
If a patient does not have enough tissue for IHC testing, does this eliminate them from consideration?
Not necessarily. I still think, again, NGS testing where you're looking for multiple biomarkers is so important to do. So I think even in the absence of having enough tissue to do IHC, I would exhaust the tissue trying to do all the testing that's available. Blood-based NGS testing is also an option. Again, that doesn't look at IHC, but it does look at HER2 amplification, and I think can point you in the right direction. The good thing about IHC is that even for people that have extrahepatic cholangiocarcinoma, for example, where many of these cases are diagnosed with brushings of the bile ducts, which can have really limited amounts of tumor in them. Blocks of tissue can be made from those bile samples, and HER2 IHC can be run on that. So you really don't need a lot of tissue to be able to do that testing. So even if you're someone that has a tumor that's difficult to biopsy, like an extrahepatic cholangiocarcinoma, and you have stents in place, when your team is going in for stent exchanges, they should be able to get hopefully enough tumor cells from the bile ducts that you could be able to check for HER2 IHC.
Okay, perfect. Incredible talk. Thank you, Dr. Ellis, so much. 2 questions. While 15% of tumors that are not amplified had overexpression on IHC, it also appears that 16% of tumors that are amplified on NGS are actually not overexpressed on IHC. Is protein expression more important than gene amplification, and thus would you not treat with an anti-HER2 therapy if amplified but not protein overexpressed?
Great question. So what we've seen in now biliary cancer, as well as other cancers like gastric cancer, is that tumors that only have amplification, either by NGS or by testing like in situ hybridization, that ISH testing, they do not tend to respond as well to HER2-directed therapies. So I think, would I still potentially try HER2-directed therapies in people that had HER2 amplification? Potentially, yes, because I do think, again, a lot of these tumors have very varying levels of HER2 within the same tumor across different tumors. So it's certainly something worth exploring, but unfortunately, we've seen that tumors that just have HER2 amplification without having the protein levels higher do not respond to HER2 treatments.
You may have done this, but can you guide us a bit more on the best sequencing strategy of these 4 anti-HER2 therapies that you discussed?
Yeah, so this is sort of the million-dollar question. Now that you have all these therapies available, what's the best way to sequence them? I do think, again, this is a very personal discussion with your team, and I think, weighing all of the options is important to have on sort of a one-on-one level. But I would say, again, with drugs like trastuzumab deruxtecan and zanidatamab now being available in the second-line setting, most people are getting treatment like gemcitabine, cisplatin, plus or minus immunotherapy as a first treatment. Getting that therapy for several months can be pretty tough, both from a fatigue, energy level, blood counts can get a little bit worn out. Certainly drugs like trastuzumab deruxtecan are fantastic, but it is very similar in terms of side effects to chemotherapy. So I think that's something important to consider. Drugs like zanidatamab, because of sort of the unique mechanism of action, has a totally different side effect profile from chemotherapy, so maybe easier from a side effect profile. So I can imagine many people favoring that as sort of a second treatment. The other thing that I would add about drugs like trastuzumab deruxtecan, which again is an antibody drug conjugate, so it sort of latches onto the tumor and then delivers a little chemo bomb essentially directly to the tumor. That drug has been studied in people that have had prior HER2 treatments and is still shown efficacy. And I think part of that has to do with the fact of something called the bystander effect. So this drug is able to kind of seep out into the tumor and sort of hit other areas. So I think it can work really well, particularly in people that have some of these mixed HER2 levels. So I would tend to think of drugs like the antibody drug conjugates as good kind of backup options that can still potentially even work after you've had prior HER2 therapies.
Okay. For someone who has stage 4 extrahepatic with HER2 3+, and they have failed the 2 tras and then the Enhertu, would Zani still be an option?
I think it's definitely still an option that would be worth trying. Absolutely. I do think, potentially getting fresh biomarker testing would be really valuable. Even things like blood-based biomarker testing can be really helpful to see, are there any outsmarting maneuvers that you can pick up on either in the blood or the tumor itself that might inform kind of next treatment options. But I certainly think zanidatamab would be reasonable to try.
So both NGS and IHC testing are performed on solid tumors, correct?
Yes. NGS
Is it
testing can also be performed in the blood as well.
okay? But the IHC cannot be done in the blood.
Correct. At least not at this point.
In the zanidatamab studies, were there any factors predictive of response other than the IHC 3+?
That's a great question. So in zanidatamab specifically, not yet, but in some of these other HER2 trials, there's some data coming out about other predictive biomarkers for response. So looking at, again, that's where the importance of NGS testing is really valuable, where you're looking at what else is in the tumor besides the HER2. So there have been some studies suggesting that, mutations like P53 that might be present at the same time as HER2 might make tumors respond a little bit less well. And there are other sort of acquired changes that we might see over time, like in the PI3K pathway, which is an important growth signaling pathway that again might sort of mediate some of these responses. But I think right now it's probably still too early to say exactly what are sort of mechanisms of response and resistance in bile duct cancer specifically, because HER2 is very common in tumors like breast cancer and stomach cancer. We end up sort of extrapolating a lot of data from those spaces. But I do think cholangiocarcinoma and gallbladder cancer are very unique. So I think this is an area of research that's ongoing.
Can you have a false positive IHC if your NGS is negative?
So IHC is a pretty sensitive test. So if your NGS was negative for HER2 amplification, you can definitely still have HER2 overexpression. And that was part of what that table was showing, that again, 15% of tumors that do not have HER2 amplification on NGS testing, which again is that sort of common biomarker testing, will still be HER2 overexpressed and respond to those tumors. So you actually, unlike the question that was asked previously about if you just have amplification and not overexpression, those tumors tend to not respond as well to HER2 treatments. But if you have overexpression and not amplification, you will still respond.
Okay. Is anything known about differential impact of zanidatamab among gallbladder versus bile duct cancers?
That is a good question. So, zanidatamab, there was a slightly higher frequency of patients with gallbladder cancer. A lot of these studies aren't powered statistically to sort of look at the difference in benefit between certain subgroups. And I think hopefully with, this phase 3 trial that's ongoing right now, comparing zanidatamab in combination with standard of care chemo, that will have more numbers of patients to be able to answer some of those questions.
You mentioned adding a new treatment to standard of care. Can you repeat that? And would that be only for HER2 or all first line?
Good question. So the trial specifically, the Horizon BTC 302 that we had the map of, is for people that have HER2-positive biliary cancer. And that trial is, coin tossing people either into standard of care treatment, which would be chemotherapy plus or minus immunotherapy, and comparing that to the standard of care plus zanidatamab, this new HER2 drug. So it's for HER2 specifically.
Okay, perfect. Can you help to explain what it means when someone has a HER2 neutral NEU IHC result of equivocal 2+ pending FISH?
Pending FISH, yes. So HER2 NEU is all still the same. Sometimes you might see it written as ERB2. If I, perhaps I can pull up maybe the slide again, or I'm not advanced enough to do that. I don't want to close out of things. But so the testing algorithm for IHC, if the tumor is 2+, that means it's sort of equivocal or indeterminate, the HER2 positivity level, which is why it will either reflex automatically or your team would request additional testing, which is usually something called FISH or ISH testing, to look to see if HER2 is amplified. So still hopeful, and I would still recommend doing that additional testing if you're IHC 2+, to see if you're HER2 positive or negative.
When will preliminary results from the phase 3 zanidatamab be available?
That is a good question that perhaps my colleagues from Jazz could answer. It's certainly enrolling right now, so usually there's some sort of early results that get reported, but I'm not exactly sure when the first interim results will be reported.
That's okay, thank you. Did most labs now perform both NGS and IHC so you can do a one-stop shop? I assume the oncologist should now request both these genetic tests when solid tumors are collected, or should the patient advocate to have both tests performed?
This is a really important question. So I would say in general in biliary cancers, it is not yet standard of care to have these panels that are sort of, when you have a bile duct tumor come in, that they're reflexively doing HER2 IHC testing. Stomach cancer, again, is a little bit further along in that many academic hospitals will have that sort of built in, exactly as you said, as a one-stop shop where they would reflexively test for that. I think it's improving in a lot of places, but in all honesty, I would say that most people have to directly ask for it. And even oncologists have to ask pathology to test for it in many cases. So that's why I would highly encourage you, if you've only had NGS testing of your tumor, and even if it shows HER2 non-amplified, which again is the majority of cases, if there is the opportunity to do additional testing on the tumor itself, I think it would be worthwhile to look at HER2 IHC as well.
Are there any studies currently to study mechanisms of resistance to HER2 therapy and how to overcome them?
Yes, no, I think that's a big area of research. Again, it's been much better studied in breast cancer and even to a degree stomach cancer, and there have been sort of lots of data coming out. Something in biliary cancer specifically is they've shown changes in a protein called SRC, that potentially may mediate resistance to HER2 therapies, but I think this is still a really early area of investigation. One of the ways in which resistance is probably driven to HER2 therapies is through pathways like RAS. So I think that might be a potential avenue in the future, is combining therapies as a way to sort of stop two important growth pathways. So I hope that will be sort of the next wave of clinical trials that are coming, is how do we, one, design better drugs to overcome this resistance, and design better combinations to prevent it as well.
Great, thank you. I think those are all of the questions. If anyone else has any other questions, please put them into the Q&A. Otherwise, thank you so much for this presentation and for sharing that information. I think it's been really insightful.
My pleasure. Thank you for having me.
Thank you. Yeah, no other questions came through, so thank you again.
Thank you.